Good morning. So for today, I will demonstrate the emergency management of shoulder dystocia. Shoulder dystocia is a birth problem, increasing in incidence because the weight and therefore the size of newborns is increasing. It occurs in women with diabetes, in multiparous, and in post-date pregnancies. This condition may be suspected if the second stage of labor is prolonged, if there is arrest of descent, or if when the head appears on the perineum, it retracts instead of protruding with each contraction. There are two mnemonics used in the management of shoulder dystocia. First is the helper mnemonic. H stands for call for help. E for evaluate for possible episiotomy to increase the anteroposterior diameter of the passage. L, legs flex or McRoberts maneuver. P, pressure or suprapubic pressure. E, entry maneuvers. R, remove posterior arm. And R, roll on all fours. Next is the alarmer mnemonic. This is an alternative to helper mnemonic. A stands for ask for help. L, legs to chest. A, anterior shoulder disimpaction by suprapubic pressure. R, release posterior shoulder. M, maneuver forward. E, episiotomy. And R, roll on all fours. For the procedure, first is to set up unique systems for calling for help in obstetric emergencies to assure that appropriate equipment and personnel are available consistent with local circumstances. This is to establish and practice a management protocol that includes all available healthcare providers. Post the protocol in the labor area so it is available to refer during an emergency. Next is to assess the woman to be transferred to the nearest consultant unit or hospital for delivery and assess the client's ability to follow instructions. I will gather all the items that I will need on this procedure. So we have here for the internal examination, we have lubricant and clean gloves. For the vaginal delivery, we have here 2 sterile gloves, 1 urinary catheter, 1 straight forceps, 1 Mayo scissor, 1 needle holder, 1 syringe with needles, placental basin, 1 chromic tube, 2% lidocaine, sterile OS, and cotton balls with betadine. This is for easy accessibility for the inspection of the external genitalia, vagina, and cervix. Good morning, ma'am. I am Angelica, your student nurse for today. May I know your name? Thank you, Ma'am Ezra. So, how are you feeling right now? How are you? Are you excited or are you nervous? Oh, mixed emotions. Okay, ma'am, so just relax because I will do an internal examination by inserting my gloved fingers to assess the progress of your labor. Is that okay? Thank you, ma'am. So, it is important to identify the client, introduce myself, and explain the procedure to obtain client's cooperation and work simultaneously. Okay, ma'am, so you will be positioned on the examination table to assess the progress of your labor. Is that okay? Thank you, ma'am. So let me assist you. Thank you. Just relax, okay? Thank you so much, ma'am. So, there are 3 positions employed for the internal examination. These are dorsal recumbent, Sims position, and knee chest position. The aforementioned positions are made best as to expose the gynecologic area to be examined. Position depends on the client's capability and the examiner's preferred position. Ma'am, I will put the drape on you for your privacy and I will just expose the part that I only need to assess. This is to respect the client's modesty and to provide privacy. Next is, I will wash my hands. on examination gloves. This is to protect myself from contracting gynecological diseases caused by highly infective organisms. I will notify other healthcare providers to assist or back me up during the emergency delivery and neonatal resuscitation. When shoulder dystocia is suspected, the nurse can be prepared to assist staying calm and calling for added assistance with the healthcare providers. McRoberts maneuver is done by grasping the mother's posterior thighs and flexing them against her abdomen. Mazanti maneuver is done by applying pressure on the suprapubic region, is done to dislodge anterior shoulder and simultaneously instructing the client to bear down while applying suprapubic pressure downward with palm or fist, 30 seconds of continuous pressure. Apply steady pressure first. If unsuccessful, apply a racking pressure. Do not use fundal pressure. In combination with the McRoberts maneuver, this will deliver the baby in 91% of cases. It is useful to understand the lay of the baby so as to apply pressure from the correct side and be the most effective. It is also useful to have a stool in delivery area to facilitate this maneuver. It is important to be above the woman when performing suprapubic pressure. Fundal pressure is to be avoided because of the potential neurological complications. If Mazanti maneuver is not possible or unsuccessful, then we will move to Rubin's maneuver. So this maneuver is done with inserting my fingers behind the posterior aspect of the anterior shoulder and rotate the shoulder towards the fetal chest. This maneuver attempts to position the shoulders to utilize the smallest possible diameter of the fetus through largest diameter of the woman. If Rubin's maneuver is not again possible, then we will proceed to wood screw maneuver. This is done by inserting two fingers on the anterior aspect of the posterior shoulder while pressure is applied to the anterior aspect of the posterior shoulder, and an attempt is made to rotate the posterior shoulder to the anterior position. Wood's maneuver is a screw-like maneuver. Success of this maneuver allows easy delivery of that shoulder once past the symphysis pubis. In practice, the anterior disimpaction maneuver and Wood's maneuver may be done simultaneously and repetitively to achieve disimpaction of the anterior shoulder. If wood screw maneuver is unsuccessful, then next is the manual removal of the posterior arm. Okay, so delivering the posterior arm is done by applying pressure intravaginally at the antecubital fossa, which causes fetal arm to flex. And I will grasp it and sweep across the chest and towards the opposite side of the fetal face. This may lead to humeral fracture if it's not done properly, which does not cause permanent neurological damage. Next is episiotomy. This increases room to work for rotational maneuvers. But nurses cannot perform episiotomy and should be done by the obstetrician. If the maneuvers are not useful, then we will proceed to roll over to all-fours position or gaskin maneuver. This is done by assisting the client to roll onto hands and knees, and I will apply downward traction to deliver the posterior shoulder that can be repeated until the shoulder of the fetus is delivered. Gaskin maneuver, moving the woman to all fours, appears to increase the effective pelvic dimensions, allowing fetal position to shift. This may disimpact the shoulders. With gentle downward pressure on the posterior shoulder, the anterior shoulder may become more impacted with gravity but will facilitate the freeing up of the posterior shoulder. Also, the position may allow easier access to the posterior shoulder for rotational maneuvers or removal of the posterior arm. Prior experience with delivery in this position is an asset. This is believed to increase pelvic size and make use of the force of gravity. Baby boy out, 12:30 p.m. If the baby is crying, then I will proceed to EINC. But if not, then I will cut the cord and resuscitate the infant. This is to safeguard the mother and the baby against infection and to facilitate the spontaneous breathing of the infant. After the delivery, I will assess the baby's motor reflex, check for fractured clavicle or humerus for possible injury, and do cord care aseptically. A complete symmetric motor response usually indicates no brachial plexus injury, which is the most common serious resulting in injury. If an injury occurred, be prepared to discuss possible outcomes with the parents after the pediatrician has spoken with them. 80% of these injuries resolve and cause no permanent damage with appropriate treatment. After the delivery of the placenta, I will check for its cotyledons if it's complete, and I will assess the vagina and the perineum for lacerations. This is the greatest risk to the mother from a shoulder dystocia. The hemorrhage is usually related to uterine atomy or vaginal or cervical lacerations. Next is I will remove my gloves after I clean the instruments and will wash my hands after. This is to limit the transfer of microorganisms. And lastly, I will document the procedure and record. This is to provide accurate data in the care of client. So, good morning. Today, I will demonstrate the emergency. This is for easy access. So, this maneuver attempts to utilize to position, attempt to position. Wood's maneuver is a screw-like maneuver. Disimpaction. Lakasan na lang yung boses. Roar. Charot. Ipapasok ulit kita sa vagina ni Mother Ezra. Wala lang. Sorry. Kiss lang tayo kasi nursing is an art. Para-paraan tayo mga Zay. Sorry. Ayan. Buti pa si baby tumatawa. Napindan siya accidentally. Antayin ko muna siya bago tumigil na tumawa. Ayun, tumigil na. Wait lang, pagod na ako. Kaya mo pa ba? Charot, kakayanan. Haggard ka na, sis. Ay. Oh! Hala. Hala, nag-rotate yung ulo niya. Roar, roar, roar. Kaya pa ba? Mama! Charot. Carry. Kaya pa natin to. Fighting! Ay. Next is I will remove. La 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 la. Remove